In my talk today, I will talk about a medical visualization and a specific topic, namely radiation therapy planning and visual analytics, so visual computing. My background is in computer graphics and in computer science. And at our research group, there is a visualization unit that has about 10 to 15 people. And we have the usual basic research grant, applied research grant. We are collaborating with companies and also via the VIAVIS, which is a public-private partnership company for applied research. And we are also involved with the University in Bergen for a very long time. So just to give you as a context, what topics we are doing in computer science. We have been doing medical visualization for quite some time. We started with blood vessels, and right now with Renata and other people, we are in cohort analysis, radiation therapy, and that's what I will mostly spend my talk on. Other areas are mathematical visualization, like dynamical systems that are described by a set of differential equations, and how can you visualize trajectories which are long-term developments of such systems. Even Viola, who actually was in Bergen for quite some time and then moved to our group back and now is in Saudi Arabia at the KAUST University, he pushed nanostructure visualization, DNA molecular visualization, and this term of visual modellytics, in the sense of sometimes modeling tasks are so complex that you need automatic support and guidance for that. Then we have Yun from Taiwan and Manu working on graph visualization, layout of city maps, for example, of subway systems in a way. And Manu is also working on perception visualization. How do you perceive certain phenomena? And recently she is also working in AI explainability. Nowadays many people are working in artificial intelligence, and one important topic is how do I understand these systems. Okay, so this is a very short overview of what we are doing, and today I will concentrate on this medical visualization, and namely radiation therapy planning. Radiation therapy is a key component in the therapy of various cancer types, and I will concentrate on prostate cancer, where this is affecting many men from a certain age, so this is a very prevalent condition. And last year at the EuroVis conference, this is the largest visualization conference in Europe, these people provided a state-of-the-art report, Visual Computing in Radiation Therapy. And I will use 1 or 2 slides from that state-of-the-art report to provide you a setting of this topic. So radiation therapy means malignant organs or cancers are radiated to kill off the cells, but at the same time, if you're using external rays, these rays are traversing other organs, and there are organs at risk where you would like to avoid high radiation, because this might harm healthy cells as well. So at the beginning, you have to do some planning. There's an entire pipeline going from the diagnosis and investigation by doctors until the treatment is applied. And during this entire pipeline, many experts are involved, medical doctors, physicians, radiologists, and also several types of data, in many cases imaging data. And this imaging data is used to plan the radiation therapy. So there's some imaging acquisition at the beginning of this stage. And with this imaging data, you have to define interesting structures. The one structure is for sure the cancer, or maybe the prostate that you would like to radiate. And at the same time, you have organs at risk that in the pelvic regime might be the bladder, the rectum, seminal vesicles, and other structures. And while you would like to radiate the target, you would like to avoid the organs at risk as much as possible. And so you have a treatment plan, and you are radiating the target from various directions, and you are defining the intensity of the radiation. So you have a treatment plan, and you do a dose calculation. How much dose would you like to bring to a certain part of the tumor? And then in certain steps, you have to do a dose plan review and the treatment evaluation. And what is right now not so common, it would be an image-guided adaptive radiation therapy. So this is very much in a development stage. And after this, you do the treatment. But the treatment is not done at once. You apply the radiation over a certain period, over a couple of weeks. And during this period, the situation is changing, like the size of the tumor, maybe the position. And as you have here soft tissue, this can also influence the shape of these organs. And if you have a very detailed planning at the beginning, at some point you should readjust your treatment plan. But this is really costly, and you would like to do it in a personalized way. And so here in these gray areas in this workflow are those where visual computing is mostly involved. And if you look closer at these individual steps, they consist of a lot of sub-steps. So if you have multiple data that is acquired, like CT data, MR data, maybe spectroscopy data, you have to register those data, bring them in the same framework, overlay them in the same coordinate system. Registration can be rigid or non-rigid, so this can be quite complex. Then if you have various data sources, you have to think about data fusion, bringing these data together to get correlation analysis. And then the data usually are maybe absorption coefficients, but they need semantics. So you need data segmentation, where you are outlining what is my target. It's the prostate, for example, but it's not so easy. Sometimes the contrast is not good enough, and then sometimes you have to take into account uncertainty. You have to define safety margins and things like that. And then you have to define organs at risk that you would like to avoid in the radiation. And if you have done this, then you can do a data exploration analysis to get a feeling how this radiation or the radiation is distributing over your interesting structures. And then at some point you have to do a dose plan review. Initially, you have a plan where should your rays end up, and then you do an evaluation that tells you maybe that an organ at risk has been radiated too much, or you can do a non-spatial evaluation where the spatial distribution of the radiation is not taken into account. And that's actually what's done nowadays in most of the cases. And these are the dose volume histograms, for example, that I will talk about. So this is the general setting, and now I will talk about a cohort study in the area of prostate cancer. And in this case, the prostate is very close to the bladder, and therefore the investigation shall determine how is the bladder affected. And this is a visual analytics study, and as it is going over several time steps and it is going across a cohort, these are several simulation runs that you take into account, and therefore you call that, we call that bladder armor. So how is this is the setup? Here you have the anatomical situation, and in this case, here it's the prostate. It's very close to the bladder, and you have the rectum. And at the beginning, maybe you do an imaging and you take a look at the anatomical slice. You can look at it from canonical slice direction, the axial slice, the sagittal and coronal slice. And then at some point you see the prostate, that's where you would get the radiation, but close by you have the soft tissue of the bladder you would like to avoid. And even visualizing it in a slice is not so easy. And here you see so-called isolines. You have a dose radiation, and the doses are like 50%, 70%, until 100%. And then you are delineating with a contour line how much radiation you get. And these lines are concentric. They are the higher dose isoline is within the lower dose one. But you see here an overlap, and the question would be, is this impacting the bladder? How bad is this impact? And then this is considered a bladder toxicity, where you might have acute problems like bleeding, or even long-term problems that may even show up after a couple of weeks or months or even years. So you have your dose radiation is defining from which angle are these rays applied. You are applying that from several angles at the same time, because then at the intersection of these rays you get the highest dosage, and this avoids that along a single of these rays you are over-radiating healthy structures. But this radiation plan is over a couple of days or weeks. In this study, it was in the first 5 days you got a radiation, and then in the following 8 weeks you got every week a radiation again. So this is over that period of time. You get several radiations. And it might be that your bladder is changing shape and location. And the biggest effect is the bladder filling. It can also be the rectum filling. And depending on the setup in your pelvis, there are certain directions where your bladder can move more easily than in other directions. And this should be taken into account. The idea would be, I have now my initial scanning, and this was used to define my radiation plan. How does this still is valid for a radiation that is happening then after 2 or 3 weeks, where at the beginning the people still get a CT scanning, but this scan is basically used to roughly adjust the tumor location, for example, but not for a detailed radiation plan. So a non-spatial analysis would be a dose volume histogram that you see here. This is basically taking the entire bladder, and you are calculating how much is the entire bladder affected. And horizontally, you have a dosage. It's a minimum dosage, like here it's 60%, and you have 3 patients, and you see these monotonically decreasing curves. And the blue curve is lower than the orange curves, and in this case, this is good, because this means at least 60% of dosage is affecting 10% of the volume. And for the orange patient and for the gray patient, they are higher up these lines, and in this case, they get a higher radiation. For the orange patient, they have about 10% or more than 10% of them get at least a 60% radiation. So for the organs at risk, you would like to have these monotonically decreasing curves, and they should decrease as fast as possible. On the other hand, for the target value, you would like to get as much dosage, in the ideal case 100% dosage, to as much as possible of the target structure to the prostate, which is affected. And so in that case, you would have a curve that is staying very much high up, and only maybe at the end is monotonically decreasing. But this doesn't tell you any variation of the dosage. Are there certain parts of the bladder that are more affected than the other? So that has been the outset of this cohort study. So in this case, a group in the UK, in the United States, where Renata is collaborating, we are investigating in a retrospective manner 29 patients. They got scanned at the beginning to make up a radiation therapy plan. Their bladder was scanned, and the segmentation was done manually. So this is a preclinical investigation to sort of get a feeling for the medical physicists how to come up with good therapy plans. It's not intended for the clinicians yet. That would be a little bit too complicated. And depending on the anatomical structure, they are coming up with a radiation dose plan, which tell you at which part of the anatomy they would like to have how much dosage. So this is the plan at the beginning, and then later on for 13 time steps, 5 for each first 5 days, and then for the following 8 weeks, once a week. The patient is scanned again, and the dosage is simulated depending on this changed anatomy. And then you have here a rich data set which you would like to answer a couple of questions. The one question would be that you're looking at one patient and you're looking at the temporal development of this patient. Especially in this case, you're looking at the shape variability of this bladder. And how does this shape variability influence where the dosage is ending up? And if you have a very low variation of the shape, maybe this might be better. The second tasks, there are subtasks that I will talk about, is about a cohort investigation. One patient might be an outlier. Maybe you get an information on the entire cohort, and you can make some, define some guidelines based on investigating a group of patients. Maybe you can find clusters. You can group these patients according to the behavior of their anatomy over time. And now let's take a look at the individual patient. And in the individual patient, there are actually 3 tasks. The one thing is to take a look at how does the bladder shape change over time. This means you have to take the shape variation over these 13 time steps. The second one would be you have for each of these 13 time steps, you have a dose distribution. This is basically a simulation, and you get a volumetric data set. And each voxel, you have a scalar value, and the scalar value tells you how much the dosage has been deposited at this voxel. And at the end, you take a look at the bladder, how much of this has there been too much dosage distributed at certain parts as compared to your initial plan that you have made at the beginning of the therapy plan. So these are 3 tasks, and the cohort tasks are very similar, but here we just look again at the variability of the shape of the bladders, but not one bladder over 13 time steps, but 29 bladders for each of these 13 time steps. So this is a richer data set. And also again, the dose distribution. But not again for one bladder shape aggregated over these 13 time steps, but for the entire group. So in that sense, the research prototype that Renata has implemented consists of these 2 parts that have similarities. But let's now take a look at the individual patient investigation. And this is now the setup. The first thing is, as I said, for each patient, we have these 13 time steps. And at each time steps, we have a bladder shape. Out of the CT data set in the slices, the bladders have been delineated. And now we have basically a triangular mesh that is describing the bladder shapes. And the radiation dosages are these volumetric data sets that tell you for each voxel how much dosage should be delivered at that point. So the next step is then to bring all these shapes into a framework where you can compare those. And this would be the first step. how can I measure the shape variability of a bladder? And here, this is done by taking a bladder shape descriptors. So this is something that you do very often. You have a complex triangular mesh here, but you describe it by, in this case, by 14 scalar values. The volume would be a possibility. Is it spherical, or is it more an ellipsoid? In which direction does it extend? So I think I have these shape descriptors described here. I'm not going into the detail. The volume is for sure very important, and there are during the procedure, the volume should not change too much. Actually, patients are told to come up for the investigation, for the radiation with a filled bladder, but you cannot fully control that. Then compactness of sphericity means, does this bladder look like a sphere or not? Then you can take the bladder, and in the inside, you could calculate the so-called inertia tensor, and then you get eigenvalues and eigenvectors, and they tell you how ellipsoidal this bladder is and in which direction it is extending. And convexity can be calculated. And so you can have many shape descriptors. In this case, we were taking 14 of those. And each of these bladders is now mapped to a 14-dimensional point. So you have a very high dimensional space. And then in this case, people are doing dimensionality reduction. So every of these 13 bladders ends up as a point in a 14-dimensional space. You do dimensionality reduction, where you would like to bladders which have the same shape descriptors. This means they are very close in this 14-dimensional space, should also be close in this reduced space. And nowadays very popular is TSNE. This is T-distributed stochastic neighborhood embedding. It is sort of calculating in the high dimensional space the neighborhood differences and tries to preserve those in the 2D space. And if you have a cluster in the high dimensional space, you will have a cluster in the 2D space as well. Maybe the arrangement of the clusters is, you have to be careful how to interpret that, that might change. And then in this two-dimensional space, you could reduce it to other number of dimensions, to 3 or to 1, but in many cases it's done to 2D because you can easily visualize that. And then you can do a clustering. Maybe I see some structures in now this reduced space, and one possibility is Gaussian mean shift clustering. You take Gaussian curves and you place it over your 2D data. You have basically a 2D point set, and then maybe you can find the classes. In our case, there were basically 3 clusters identified. The green cluster was those of bladder shapes that are really small, and then the orange ones are the larger ones and with other shape parameters, and the third cluster was sort of the outlier one. So the first visualization to give a broad overview was this matrix arrangement. On the horizontal axis, you have the time steps, again, these 13 time steps. On the vertical axis, you have the patients. Not all of them are shown here, just 11. But you immediately get an overview for each of these cells. A cell corresponds to a patient at a specific point in time. Here, the time step 0 means the beginning of the radiation therapy. And for patient 0, you see, the shape is not changing very much, and also the bladder shape stays in the same group. Maybe then it's switching a little bit. If you look at some other patient here, the bladder shape is switching between is switching between various between various of these clusters. So do you hear me still very well?
Yes, I can hear.
Yeah, okay. So my computer was acting up.
Okay.
and you have three clusters, and within this cell, you position the one cluster to the left, the second one in the middle of the cell, and the right one in the right one. So if you look at the column, you immediately see also for at a time point which of these clusters are showing up very often. So this is an overview representation. The second representation would be sort of to get an aggregated a representation of the bladder. So we have 13 time steps, and how can I calculate from these 13 time steps a median or an average shape? And so this here it's done with something that is called the coverage levels. You have the central point of the bladders have been aligned, and then you can calculate for a position in your volumetric space. You can calculate in how many of these 13 bladders is this voxel lying, which means you get a value between 0 and 13. So you're calculating coverage levels, so probability distribution functions of the shapes. So you're taking all of, with each shape from each point in time, you're looking at which voxels is this covering, and you're increasing the counter there. And then sort of this coverage level is an aggregated representation of all these 13 bladder shapes. And then you can calculate probability levels. The 50% level means I'm identifying those voxels which are lying in half of these 13 time steps in the respective bladders. In 75% means in 3/4 of the time the voxel is inside. So this is a way of reducing the information, and we are showing here the interesting 5 interesting levels in these cover data. And the 50% level is shown as an isosurface, and the rest is shown just as an isocontour. So you have here a silhouette, and if you change the viewpoint, this silhouette is changing. And actually what is interesting is the difference between these silhouette lines. And if I have a large difference here, this tells me that the shape of the bladder is changing here very much. And these silhouette lines are also projected on these 3 canonical planes, and here you see also in which direction the bladder shape is not changing very much, and here it's changing very much. Maybe here you see also the area where the spine might be in the direction of the spine, the change of the bladder is small. So this is then the aggregated way of showing all 13 bladders over time. The next thing is the dosage distribution. And here you have volumetric data, and you have even 13 volumetric data. That's too much. That would be the visual occlusion would be really high. How can you show that? We are not showing the dose distribution for each time steps. We would like to show it on these aggregated coverage levels, and not even on all coverage levels, but on these few selected ones. And so what we can do is each of these coverage level could be defined by an isosurface. We just show here the one isosurface for the 50% coverage level. And then we have the dose information on each point in time. So we would have at each position of this isosurface, we would have 13 scalar values. Again, a distribution in a way that is describing how the dosage is changing there. But for the moment, even showing this coverage level on this sort of spherical surface is complicated. And at each point, we would have here this dose distribution with an average and a variance. And from the data we get at each position 13 scalar values. And it tells you also if the variance is small, then you're pretty sure how much dosage is ending up there over the period of time. And if the variance is larger, this is not an ideal situation because you have a large variation. But how can I show that? I mean, if I take these 5 coverage levels, I'm not even taking all of them, but just 5, that's too much. And they are nested into each other. So this is like this Matryoshka setup. And showing 5 nested isosurfaces is very difficult. You cannot interpret that very well. So we are doing something what is very often done in geographic mapping, where you take the surface of the Earth and you are unfolding it, mapping there. So a lot of cartographic projections that are available. And we do this actually for all of our 5 selected coverage levels. And then we are placing them next to each other. So this is in comparative visualization, not putting them on top of each other. That's too complicated. The second way of bringing these complicated 2D surface onto a flat planar situation is flattening. It's unfolding, it's in cartographic projection, take the spherical surface and unfold it. Or if the flattening would be, if it's a sphere, take the more interesting half of it and project it into 2D. So what we end up is in a planar representation of these coverage levels, and where we can show the dosage distribution, and maybe the variance, the size of the dosage is controlling the color, and maybe even the variance is controlling the transparency in a way, so that you could say, if I have a high variance, I'm unsure about what's going on here, and then I'm increasing the transparency. And here then you could see immediately in which areas the dosage is accumulated. So this was sort of bringing together the bladder shape and the dosage. Where does it end up? For the single patient, it's also the toxicity. Now we would like to compare. At the beginning, we had an initial dose plan, and what's the toxicity risk? And what is done here is we have an initial plan, and then we know how much radiation has been happening. We know this in this distribution, and then we can compare our initial dose plan at a specific position in the volume or on these 2D unfolded maps. On the one hand, we have the intended intensity, and then we have how much intensity really ended up there with an average and a distribution. So this distribution is shown here. And if our intended intensity at the beginning is larger than the average, or is to the right of this distribution, then this is a good situation because it's under-radiated. We were initially accepting a much higher intensity, and during the treatment, much less ended up there. On the other hand, if our intensity is to the left of this Gaussian distribution that is describing the radiation that ended up at this specific position, you had an over-radiation. Over-radiation means more radiation ended up at a specific place. And here you take again your 50% coverage surface, and maybe you can encode then in green the under-radiated areas. This is good. And the over-radiated areas you might analyze much closer. Okay, so this was the individual patient. The cohort of patient is in a way very similar. Here I just don't have only one patient, but 29 patients, but several of the steps are the same. In this case, if I'm looking at the bladder shape, I'm not looking at the bladder shape of one patient, but all the 29 patients. But in this case, it just means that in my high dimensional space, I have more data points, not just 13, but 13 times 29. And from the analysis, the two tasks are the same. The one is shape variability of the bladders, and we have now the bladder shapes of 29 patients. And what is done here is, again, calculate shape descriptors. Again, 14 shape descriptors for each bladder, but we have now much more bladders. Then we do, again, dimensionality reduction, and we are clustering in these two-dimensional space, and we get 3 types of clusters. But now we, at each point in time, we don't have one bladder that falls into one of these clusters, but we have 29. And so we, as an additional overview figure, we propose a stacked bar chart that immediately tells you at each point in time which of these clusters are prevalent. The small clusters in green, the larger one in orange, and the sort of outliers in blue. And you have a line connection here that tells you that from one time step to the next, maybe one bladder shape moved to another cluster, for example. So this gives you a quick overview. For the here we see this 2D space that resulted from dimensionality reducing the 14-dimensional space. And here you sort of see also where these clusters have then been identified with this mean shift, Gaussian mean shift cluster. You can also calculate the average shape variability by taking all the bladders. Now you have many more because you're also across the patients. But you can also, and this is probably more interesting, as you have a clustering into 3 different shapes, 3 clusters, you can aggregate the individual clusters by themselves. So the green cluster bladders are condensed, aggregated into these coverage levels, and also the other clusters. And then you can investigate each cluster by its own. So and for the combination and the identification, where is the bladder affected very much, you have the same strategy. You take your dosage plan, but that's way too much information. You're reducing it to these 5 interesting coverage levels, but these coverage levels are now coming from not a single patient aggregated over time, but of an entire cluster that is aggregated over time and about several patients. You can have also this flattening or unfolding, and again having this juxtaposed representation. Then I don't want to go too much into the evaluation. This was a qualitative one. As I said, it's not intended for clinical usage yet. This would be too complicated, too costly, and for the clinicians, the setup is too complicated, and it still involves several levels of uncertainty and things that are not quite sure. So it's more for the medical physicists so that they can explore the data, identify hypotheses, maybe come up with guidelines. Maybe if you know that a patient falls into a certain group, one of these 3 groups, you could have different suggestions for the radiation treatment. And so there were only qualitative evaluation results for the moment that people can use this tool. It's cumbersome, but coming up with a radiation plan takes them hours anyway. So also to have a more personalized look at the situation, and also looking at a few of those time steps is interesting for them. And it might also help new physicians and physicists to get a better understanding what happens during such a radiation therapy. Okay, so with the bladder runner, some concluding remarks is it brings together the anatomical shape and then the simulation of the dosage. And the idea would be to, in the long run, get better guidelines for clinical therapy, or maybe moving this to the clinical routine at a later point in time. It would be interesting to involve other organs as well. Close by to the bladder, there are the seminal vesicles, which by younger men you would like to avoid because that might produce infertility, and the rectum is affected, and so on, other anatomical structure. And especially the bladder toxicity data could be included in a later study when you find out how negative effects have shown up. You could put this then into perspective in how does this may relate to your dosage and your affecting the bladder. So the pelvis runner, this is a follow-up work which I will not explain, but here we, in detail, here we took other organs into account. Here we see again the bladder, but also the prostate, the rectum, the seminal vesicles, and also interfaces between the organs. And here have been glyph-based representation proposed that at a glance tells you about the variability. And if you have here a large color variation, that tells you there's a large variability. In 3D or 2D, you see these bands, and these are sort of statistical information that tells you the variability at a certain place. Here I have a much larger variability like than in other places. So I think I would like to wrap up this and come back to the general issue of visual computing in radiation therapy planning. I told you this entire pipeline. It's just there in the middle where imaging is done, where visual computing comes into play. It would be really great to have a personalization for designing more effective treatments. Personalization can be looking at patients or group of patients, not having a plan that has to be applied for all the patients, but also what is interesting in intra-tumor investigation. Certain parts of the tumor behave differently. Maybe you have a necrotic area that is dead already anyway. So this is interesting. For the shape variability, we were taking into account 14 parameters. You could have even more features. Maybe you are using artificial intelligence, deep neural networks, for example, where they are automatically identifying maybe interesting features. If your data is increasing, your visual analytics is getting cumbersome because you need to have for interaction and interactive feedback, you can do progressive visual analytics. You're just, for the moment, taking a small part of your data into account to have a faster feedback. But even with the small data, this should be accurate enough. Or guided visual analytics so that you get hints how you should maybe modify your dosage plan. And so the idea would be to keep the expert in the loop, but support the expert in the understanding. Also, analysis between the patients, because of the complexity and dimensionality, can get cumbersome. And with this dimensional reduction, this is helping, but you have to be aware you're throwing away some information and it takes some time to understand what you're doing. And there are all kinds of mistakes and errors that you're doing in each individual steps, and they are non-linearly interacting with each other. So you have here uncertainty, and the uncertainty in the propagation and also in the accumulation. That has to be taken into account. A clinician needs, to a certain degree, certainty. Okay, so I could talk about the visual computing. That's actually my area of expertise in a larger context, but I think I can provide the slides, and I'm quickly going through it. What we have seen in this bladder analysis, it's comparative visualization. You have the same object, but in many of those, how can you compare those? You have to define a metric. And in many cases, you have a multi-objective visualization and optimization. I want to radiate the tumor very much, but I would like to avoid organs at risk. So this is the objectives are contradicting each other. And you would like to make decision making, and uncertainty is involved. Sometimes you get data and the data is contradicting each other. How do you handle those? And in visualization, often you have a qualitative representation of the data, but you would like to have a quantitative one so that a decision maker can say, from a certain threshold on, I have to do something, and otherwise I take another therapy. So a quantitative visualization interaction would be nice. And here we have seen this in the bladder runner as well, this interplay between captured data that is measured and on the other hand, simulation, computational science. So this is very interesting, how to combine those. And if you have a lot of data, statistical visualization is aggregating the data just to an average and then a variance. This maybe is too much. Maybe you do a grouping in between, showing all the data is also visually cluttering and overloading. But so maybe you have to find a sweet point in between. There are a lot of parameters involved, and you need to get a better understanding how these parameters are influencing the sensitivity. And actually, during your investigation, it would be great that you immediately could influence the dosage simulation. So that would be steering the simulation directly by visual feedback. Visualization in the wild would concern how can I bring this into a clinical setting where you have time constraints, reliability constraints. And maybe in the past, data was so much complicated to get. So all your investigation was data-centric. Maybe we would like to go to a task-centric approach. You define a task and you are selecting the appropriate data, maybe not take all of that. Visual analytics helps to optimize the analytics process, but maybe we need to model itself and come up with new and better models. And in this way, how to help this modeling process so that you don't have to define all these very many components yourself. And then at the end, machine learning is now a buzzword, but to understand it needs visualization. So this is interesting. On the other hand, you can also augment your visualization application with machine learning that is helping you to automatize those areas that can be and leave the fuzzy thing to the expert that has to make a decision. Okay, so that's basically what I wanted to tell you. I think I'm a little bit over time. I will stop here. The take-home message is that we have done here a cohort study in a developmental setting to better understand the shape variability and bring it in relation to dosage plan and to personalize radiation therapy in the pelvic area. So thank you very much.